Hi, everybody. I'm going to keep it really short because I want to get on to our speakers, but just very quickly, next slide. The key thing about group clinics is that they fit incredibly well into for delivering what we describe as simple care. So this is a definition of the different types of clinical interventions that we need to get delivered by Christensen. And simple care is often planned and routine and driven by guidelines and protocols. It will often have a strong element of self-management or rehabilitation. So obviously a CVD prevention approach, lipid management, hypertension management, these are all very clearly defined. There's often a sort of first choice of drug treatment with clear targets and clear guidelines. So it really lends itself well to the group clinic model. I just wanted to highlight that the modern general practice guidance from NHS England actually encourages the use of group clinics because it supports personalisation. And when we're trying to support people to make lifestyle change, often in middle age, when there's a lot of stuff going on in their lives, a personalised care approach is really important. So in terms of endorsement from NHS England, it is described as shared medical appointments in this guidance, but it very clearly highlights the benefit of the group clinic model for things like CVD prevention. And the evidence shows that not only is this going to improve quality for you in terms of CVD prevention, but also it's going to free up time. So this is evidence from diabetes group clinics, but the same we're seeing the same in every group clinic model that we support in general practice. You get an increase in compliance with QOF because that results board highlights things that you've missed getting measured, like missed blood tests, missed blood pressure measurements, etc. You can calculate that for every 500 patients that you review in clinic equivalent. Have you got me still?
Yeah, you've come back. You paused
Can you
for
hear
a second. You stopped on 500 patients.
Okay, so for every 500 patients that you manage using group clinics, you can free up a 0.5 full-time equivalent nurse. And compared to one-to-one appointments, we see more improvements in HbA1c and blood pressure, obviously key to CVD prevention. Patients report improved quality of life, improved knowledge, greater trust in their clinician, and perceive the group clinic model as delivering a higher quality of care, even though it doesn't actually do that. It delivers the same quality as a one-to-one appointment, but it's giving a better experience to people and also importantly also to staff. So just ending with a little bit of a understanding of why the group clinic model actually has such a positive impact on staff experience. And what we find is that nurses in particular really, and allied health professionals as well, really find that the group clinic model supports them because they have a sense of autonomy, because whenever we work with teams, we give them that autonomy to redesign what is in effect quite repetitive care because it's protocol and guideline driven. And they feel as if they've got more time with patients and it adds value. And I'm sure you'll hear that from Saloni today in terms of her work. They make a much deeper connection with their patients, and that provides them with more insight and helps to build empathy and respect. And they gain a lot of joy from practicing this way. And because of that, it has a really positive impact on retention. And that's really important in general practice at the moment because, the retention levels, particularly amongst nurses, are really worrying. Next slide, please. So also remember that the group clinic model fits incredibly well with the 10-year plan. It helps you to create community capacity so that you can remove care from the hospital into the community. You can use video group clinics, and they're a great skills accelerator, which is a way of driving the switch to digital, and they create masses of time for prevention and also have a greater impact on behaviour change than one-to-one appointments, and that is proven in research as well. So all in all, they seem to be very much of the moment. And let's hand over now to Emma to tell us about her experiences of running, about the work that we're doing together with Emma in South Yorkshire around CVD group clinics. Emma, over to you.
Thanks, Georgina, and thanks for asking me to talk today. So I'm the Nursing Director for the South Yorkshire Primary Care Workforce and Training Hub, and I'm going to talk to you a little bit about what we're doing in South Yorkshire and how we're going about it. We're still in the beginning of our journey with group clinics, but when we came to look at group clinics in South Yorkshire, we realised that it's not really very widespread. And as a training hub, we really wanted to address this because it's very much on the national agenda. And as Georgina has been explaining, there's very good evidence that group clinics work very well. And patients like them, they have good outcomes, and clinicians enjoy delivering them as well. So we managed to secure some national growth accelerator funding, addressing this particular group clinic model. So it's looking at cardiovascular disease group clinics for men and for women separately, for people aged between 45 and 67 years old. Next slide, please. So the aim really of this project is to look at the feasibility, acceptability and sustainability of general practice nurse-led group clinics, and they're very targeted at men and women separately. So those clinics will be run as unisex clinics, but we particularly wanted to look at adding on to those clinics things that were relevant to those men and women. So for example, we've got we're doing menopause, we're doing cardiovascular disease and menopause conversations for women, and cardiovascular disease and mental health conversations for men. So next slide, please. So this is talking about women. So we know, don't we, that women aged 45 and over really experience inequalities in relation to cardiovascular disease, especially after the menopause. And the funding that we've got looks to how we can keep people in work as well. And about 20% of the workforce that women in the workforce who are going through menopause either reduce their hours or stop working altogether. So it's really creating that environment where people will come along for their normal blood pressure review, cardiovascular disease review, whatever that form that may take. They get the QOF boxes ticked, but also we open up conversations around menopause for the women, and we're looking to join with local partners as well who operate in that space to be able to signpost women to local services. And it very, very much will be dependent on who is delivering that clinic as to exactly how that menopause element will work as well. Some people may, we have some nurses who are experts in that area and are prescribers and will be able to do more with the women, and then other nurses maybe have just got a general overview of menopause and will be able to signpost effectively to local services. Next slide, please. So with men as well, we know that there's the men's health policy strategy has just been launched in December, called Men's Health: A Strategic Vision for England. So that's come at a really good time. And we know that there are higher rates for death by suicide, and 75% of deaths by suicide are actually men. And there's also higher rates of cardiovascular disease, obesity, smoking, and undiagnosed hypertension and alcohol use in men as well as lower engagement with NHS services. So we're really trying to help to think outside of the box about how could we engage men differently. The group clinics that we're looking at with men, we're thinking about going out to where the men are, so potentially a community centre, a mosque, a church. You know, where could we go and deliver clinics that would be where the men are anyway. And again, it would be around cardiovascular disease, so getting some cough boxes ticked, but very much looking at how can we help to support men to stay in work, have those conversations, and partner with local services around signposting to things that are happening locally with men as well. The next slide summarizes it all quite nicely. In the middle, you can see the blue circles are the key aims of the project. So looking at cardiovascular risk reduction, but also keeping people in work. And then we have the women's only group clinics and the men's only group clinics with the add-on of extra support in different areas. So that's quite a nice infographic just to summarise what we're aiming to do within South Yorkshire. Next slide. So our particular initiative, like I said, we're still really quite at the beginning of this initiative. We have got funding to roll out training and support for 20 practices, or PCN can do this as a PCN as well, to be a part of this initiative. And I'm glad to say we have been oversubscribed. We were wondering how it was going to go because, like I say, within South Yorkshire, this isn't embedded practice at all, but we've had a huge amount of interest. And I think that just shows that the direction of travel, you know, with trying to address access and trying to think differently and think outside the box of how we can reach people and address health inequalities as well. So we had to do quite a lot of communication with practices and networks. And I think that's where the Training Hub really came into its own, because we sit quite well alongside the practices. So we have got a good relationship anyway with the practices. We then did an initial webinar with Georgina and Alicia to talk about what would be involved in a group clinic, similar to what the webinar you're attending now, and then what would be expected of the practices as well. And part of it is that we've got a very comprehensive training offer. So they will receive all the training and support as well for actually rolling these group clinics out. And we decided to give the practice an honorarium as well, that they can spend at their discretion to support this as well. And then we're onboarding and collaborating with various VCSE partners as well to really draw them into this space, because they've got so much expertise. And I think it would be a huge loss if we didn't collaborate with those partners and draw them in. And then what happens is that there's a national co-design session for the women's group clinics and the men's group clinics. We invite people who are experts in these areas to input into thinking what would be a great blueprint for this group clinic. We take these to the teams that have signed up, and we have local co-design sessions then as well with them. And then they have continued support and help and dry runs of what the group clinics should look like, and implement the group clinics then. So this project is going to run for about a year, and the practices have all signed a very detailed MOU, so they're very aware of what they're going to be involved in, what their expectations are. And we're in the process of commissioning the University of Sheffield to do an independent evaluation on this project as well. Next slide, please. This just gives a little bit of a timeline for, and you know, how did we do it? Where are we up to now? Like I said, we're just at the point now where the teams have all signed up. They've all signed their MOUs, and they're all embarking on their initial training. So they will complete the training. They will have their face-to-face dry run group clinic training session as well before they go on to develop and deliver their own group clinics. So you can see here that we've got 20 practices signed up. The co-design workshops are in process. They'll have their face-to-face mobilisation days after they've completed all their e-learning and self-study. Okay, next slide, please. And then the evaluation is a really key part of this project. I don't think, as far as I'm aware, that CVD clinics for men and women have been run separately, especially with the addition of menopause input and mental health input for those different patient groups. I don't think that's been done before, so we're looking very much at evaluating this in a robust way. So we're looking at these different things here. So we're looking to see, the university is going to be looking to see, how can practices deliver and sustain the unisex group clinics, and what factors support or hinder success as well. With the acceptability and experience, we're wanting to know, safety, value, trust, motivation. Does it influence job satisfaction, retention, well-being? With the outcomes and effectiveness, how does it change patients' confidence, lifestyle, well-being? What are the outcomes for the patients around this? And also assess whether the model improves access, engagement, inclusion. So we're trying to identify barriers to it all as well. And then, of course, looking at the workforce and system impact as well. How does that impact those people coming to the group clinics? Does it keep them in work? Do they say that they would have gone off work without this kind of support and signposting? But also, how does it influence the workforce within general practice, the people who are delivering the clinic? How does that influence them? Are they more likely to stay in their job as practice nurses, for example? And we're also wanting to look at the economic aspects of it as well. So looking at the cost, the productivity gains, and the value as well in that way. So like I say, we're at the very start of our journey, but very excited to be on board. And there is a huge appetite within South Yorkshire for doing things differently and for this model, looking at group clinics. And like I say, I've been surprised by the overwhelming interest we've had to sign up for a project such as this. And I'd be happy to come back and tell you how we've got it on at another webinar. So I think, is that my last slide? Thank you.
Hi, darling.
That's brilliant. Thank you so much, Emma, for giving us. Oh dear, somebody's come off mute. Alicia, can we sort that? Brilliant.
Yeah, I'm finding it.
So if anyone has got any questions that they would like to ask, do pop them into the chat, because unfortunately Emma has to leave us just around 1 o'clock. So Claire has posted, how are you engaging individuals to attend? So Emma, do you want to say something about the work that we've done to research this in relation to men, and what we've learned around that, and also the sort of different strategies that we're going to use for men and women? It is going to be down to the practices, but we are going to give them some guidance, aren't we?
We are, and I think it absolutely will be down to the patient population that the different practices are trying to engage. Interestingly, a lot of the practices that have signed up for this initiative are in very deprived areas, so it will be interesting to see how they get on. But we know that we're going to have to look at engaging men and women quite differently and reaching out to them quite differently. There's quite a lot of group clinic work nationally already been done within menopause, for example, and CVD. We know that women quite readily engage on that kind of forum, but men don't necessarily at all. So we're going to look at that. I know we're talking about engaging football clubs potentially as well, and looking at if we've got some people who can headline this for us and encourage people to come to the group clinics. But it's very much we're engaging with the local partners to look at this more fully, aren't we, Georgina?
Absolutely. So we've prepared some resources which are which those of you who are on our training program will be able to access. And if we could carve out, Alicia, we can put those in already into our library, in our route map around women only models of group clinic and men only, and some of the sort of insights that we've researched around how to kind of work differently with women and men in group clinics. And the bottom line of it is that men generally don't engage very well with health services, as some of you probably know. And we have to really think differently about how to work with men. And that's why reaching out into the community, working with employers and that kind of thing is really going to be key. Samantha, you've asked, can we share the planned group clinic model with you? It's still in its design phase at the moment, because as you've seen from the presentation that I did earlier, it's really, really important that you allow the professionals who are working with patients the autonomy to design their own group clinics. But once this program is up and running, we will be in a position to share some of those models, and we'll be also publishing case studies that share this once we've got that learning. There's a couple of questions that we can answer in the chat. How many do you come to each session? I think, Elspeth, you might have missed it, but that's already been covered up front in the presentation by Alicia. It's about 6 to 8 online, 10 to 12 face-to-face. The sessions are usually about 90 minutes, and that's going to be the same as well. And these, I'm just helping out here because I know that Emma has to go in a moment. They will be about 90 minutes, and people may only attend one session, or they may have to attend a number of sessions. So if I can't answer the questions, Emma, today for you, I'll certainly pass them on for you to do. But thank you so much for being with us despite your really busy schedule. So yeah, hopefully you all agree. The reason we asked Emma to actually join was because we think this idea of splitting men and women in middle age to work on CVD risk is a really powerful thing, and it's in some ways very surprising that hasn't happened previously. And we're really hoping this project is going to give some insight, because there will be a very thorough evaluation of it by most likely the University of Sheffield. So let's move on to Saloni, who's going to take us into her world. Saloni, welcome, and share with us her experience of doing group clinics, which she, as you can see from her little slide there, feels are really magical. So Saloni, share the magic with us.
Thanks so much, Georgina. Hope you can all hear me. I'm going to talk about how we've delivered cardiovascular disease prevention methods through group clinics and what we've learned along the way over the last few years. So my name is Saloni. I'm a GP partner in London at the Greenfield Medical Centre. And as Georgina mentioned, I'm very passionate about advocating group clinics and integrating lifestyle medicine through these, and both virtual and face-to-face. And I really do believe that they're magical. I did some training with ELC in 2021. That was together with the North Central London Training Hub. And then my passion kind of arose from then, and we've been integrating group clinics in practice ever since then. I've also expanded into the private sector, where I use group clinics for women's health, particularly menopause. Can I get the next slide, please? So I'm going to give some real-world examples of how we've used group clinics to deliver cardiovascular disease prevention through cholesterol management, what worked, what didn't work, and how this can be replicated in routine practice. So we all know that in the NHS, the 10-minute consultation rarely gives the space and time for the meaningful conversations that patients really need. And group clinics offered a vision, not just as an add-on, but as a vehicle to change the model of care. And that was the inspiration for our journey. We know that cardiovascular prevention fails not because we don't know what to do, but because we don't have the time to support understanding, shared decision-making, and sustained behavior change that our patients know. And for me, I was quite enthusiastic at finding a new way of working, and I knew that group clinics were the way forward. I loved the feeling of connectedness and community to support healing and patients feeling better. It's sometimes, I mean, it's always overwhelming trying to start something new, but it just needs a bit of initiative, I think, to start. So I sort of took the Nike approach to just do it and jumped into doing group clinics in the NHS. Can I just get the next button on the slide? Thank you. And one more. Thank you. So I did an initial pilot in my team. It was funded through an innovation and practice scheme, which was looking at the use of innovation to increase access to care. And we completed 15 virtual group clinics with a total of 40 patients, which covered a range of clinics from weight management to chronic diseases and menopause. And we found after a brief analysis that having these group clinics had reduced the ongoing demand of GP appointments, and the patients formed a strong peer-to-peer support. We had good patient feedback, and we proved that group clinics could deliver lifestyle medicine effectively and could form part of our prevention strategy. Can I get the next slide, please? We celebrated our first year of delivering group clinics in practice, and we learned quickly that patients and staff enjoyed the sessions. And we wanted to carry them on despite the funding finish. Like any good pilot in the NHS, often the funding dries out on these projects, kind of cease to work. But we knew that this was really important to carry on. We knew that the administrative burden was high. It took quite a bit of technology to learn how to really automate the process, and it was administratively heavy. But we used AccuRx, which is an automated texting service within our borough, and we used session planners that helped us really guide a smooth flow of these group sessions. It wasn't designed as a prevention project initially or as a cholesterol project, but our initial data helped us shape where group clinics had the biggest prevention impact. And I'll talk more about why we picked hyperlipidemia and how this has been our most successful virtual group clinic. We learned that training is essential, and we encouraged all of our members to have some training for confidence to ensure the smooth flow. And this sometimes involved having a mock session in the practice where we gave everyone role plays and pretending to were patients, and then they could really feel how the sharing really made an impact, and that spurred on the magic in our clinicians to go forward. And we knew that collecting data was essential if we wanted to scale. So the key insight to these initial pilot of group clinics wasn't just a nice trial, it was a model worth embedding into our routine clinical practice with longevity. Next slide, please. And it's important to be honest about the limitations. Group clinics are not for everyone. We had a DNA rate of about 30%, which we felt was slightly more than the traditional one-to-one DNA rate, but this reflects the mindset shift towards a group format, and any new intervention takes time for patients to come round. There was a significant administrative burden initially, which I mentioned, and particularly before automation, our admin team was spending quite a bit of time trying to contact patients. But as we learned to automate this, we reduced the time spent at administration. As with any virtual model, we encountered technical problems, connectivity, platform familiarity, and troubleshooting. We also acknowledged that there was some digital exclusion because virtual delivery disadvantaged people with low technical confidence, and we had some language barriers. And over time, we've learned to overcome these barriers. So for example, for digital exclusion, we now have our admin team who are happy to download apps for patients and to connect them onto the teams. And we are having sessions with interpreters to overcome the language barriers. And this is kind of how we learned and grew. Next slide, please. One more click. Perfect. And the next stage was integrating. We chose hyperlipidemia, and we found that this worked well for our clinics because it was a common measurable diagnosis and ideal for shared decision-making with a focus on lifestyle change as well as, of course, medication. It was the part of our cardiovascular disease prevention that had the most repetition and the most clinical appointments for results discussions. So we felt that this was a need within the system, and we focused on that. We ran the hyperlipidemia clinics every 6 weeks, and this is supported by a website, which was just a very basic landing page, AccuRx, so texting automation for our patients, and online booking systems. And the difference at this stage was it wasn't a pilot anymore. It was part of our routine practice, and it delivered. We had good patient outcomes, consistent delivery, and sustainable systems. This was mainstreaming in actions. And what we learned from each session, that it wasn't the GP giving the medical information that helped our patients change behavior and stick to their goals. It was the peer storytelling and the shared learning experiences and normalization of change and taking control of health. This had the biggest impact. So my advice would be to kind of looking at cardiovascular prevention. This is something that you can deliver with confidence, motivation, sustainability. To really integrate this into your practice, it's best to pick one condition. We ran the sessions virtually, but if space and logistics allows, obviously face-to-face has a lot more of a meaningful aspect to it with body language and patient communication. We had a fixed structure, which I'll talk about shortly, and fixed cadence to really ingrain this in part of our practice. And we automated our administration. And we found that by discussing cardiovascular disease prevention in a group setting, it reduced the repetition and it freed clinician time to focus on a meaningful shared decision-making plan, and patients were more inclined to stick to their goals. Next slide, please. So this is a little bit on the impact. We delivered 90-minute structured virtual group clinics over 2 years. It was led by myself, a nurse facilitator, and 1 admin support. Our patients were identified through EMIS searches. We used our hyperlipidemia QOF. If anyone's not working in a GP practice, this is the list of our patients who are registered as having high cholesterol. And we also asked our team members to flag any high cholesterol results over to our admin team to invite them to these sessions, because that personal touch of a clinician referring a patient always have a bigger impact. We had a very small exclusion criteria, and that was largely a total cholesterol above 7 or triglyceride above 10 to really maximize our inclusion. The patients booked on an online link on a very basic website landing page. They received text message reminders and some confirmation calls, and they completed a pre and post questionnaire. Each session began with an introduction, a consent and confidentiality check. We then encouraged group interaction through a discussion board, which showed everyone's cholesterol results. And we did a one-to-one review in the group setting of each patient's individual results, and then ended with individual SMART goal settings. We collected some feedback right after the session and also at 6 and 12 months. And we completed a blood test at 6 and 12 months. And we found that this format strengthened our peer support, improved their patients' understanding of cholesterol, and enabled us to personalize this care at scale. So you can see from the clinical outcomes, our review after a year showed a 64% recorded reduction in biomarkers, and that was total cholesterol, non-HDL cholesterol, and triglycerides, and that these were stained at the 12-month mark. And these were our downstream markers of effective prevention. We also looked at patient activation, and really this was the win. We found a 20% increase in patients' knowledge of treatment options, including lifestyle changes. We found a 10% increase in their confidence at preventing future illness. We found almost 70% felt that the groups helped them stay on track. Almost 90% were willing to attend again, and nearly half of the patients rated the sessions 10 out of 10 with satisfaction. And these are the elements that are actually required to reduce future cardiovascular risk. We looked also at a system and a workforce impact because it went beyond the patients. Clinicians were satisfied, there was less repetition and more meaningful partnerships, fewer follow-up appointments, and freed up capacity, thus making this a scalable approach. This was a poster that we presented at the British Society of Lifestyle Medicine in 2024, with an overall conclusion that virtual group clinics for hyperlipidemia were feasible, scalable, and improved both clinical and patient activation outcomes in primary care. Next slide, please. And this is just some examples. So over on the left is our very crude website. It's literally just a landing page with some information. Where it says unavailable is where patients would book into the link. And this is some information back from clinician feedback. And you can see clinicians did think that patients benefited. They saw positive feedback. It reduced repetition, and they felt that this was part of a collaborative working experience. Next slide, please.
Thank you so much, Saloni. That's really helpful and a great overview of the work that you've been doing. And it's great to see how it's grown over the years as well, which is, it shows, you know, it's very much about sticking with it, isn't it? You know, start small, but then you can build on that. The one question that we've got in the, well, there's two questions now, actually. One is, what has been the impact on costs? Have you been able to quantify any cost savings, staff being released, that kind of thing through the group clinics? And also, are the group clinics mainly led by GPs or practice nurses or other disciplines? So what's the sort of workforce that you're using?
So on the cost, that's the next part of the analysis. So we've looked at appointment reduction. So for the same patient presenting back for hyperlipidemia, for example, over the next year, we've seen a 30% reduction in appointments compared to patients that have not gone through the group clinic. Having more costs, where cost analysis is what we're going through now with our financial team. So I don't unfortunately have the numbers, but watch this space. I'm hoping that the next part is some real quantitative numbers that can drive the change forward. And then the next question was, who's running them? So it started with myself and a clinical nurse and our admin team. The cholesterol is now run by our practicing pharmacist and our administrative assistant. The pre-diabetes is led by a nurse and our admin team. And the cancer project is led by a combination of 2 facilitators for each session. So it's called the Connect course, and it's a set of 3. So it's slightly different to the prevention, which was just a one-off group clinic. This is a set of 3 group clinics as a course. The first one is led by a GP and a well-being practitioner. The second part is led by the dietitian and our social prescribers, and the third part is by social prescribing and GP. So we're really using our R's team, which are our extra roles, and having a real multidisciplinary approach through group clinics.
That's amazing. That, I think that really clarifies it. And there's been a few people in the chat. I think there is a little bit of a sort of a misunderstanding that, you know, group clinics always have to be necessarily a kind of one-off. That's not the case. If you've got more complex patients, or you can do a little bit of a kind of a bit of a hybrid between a group education and a group clinic kind of model, can't you? And involve different people who are in effect delivering kind of therapeutic interventions that they'd otherwise do one-to-one with those patients, but they're doing it in that group setting. So a common question we often get from clinicians, and we cover this, the issue of prescribing in our training as part of the advanced clinician skills training. But Arshad has asked, what is there any problem prescribing on the back of the clinic, which is interesting because actually, generally speaking, where the prescribing happens is in the clinic, isn't it? Do you want to sort of share a little bit about how prescribing happens in a group clinic?
So the way we've done it, it's our patients at our GP practice, so we have access to all of their health records. So prescribing is safe. And at the end of each session, when we set their personal goals, if a patient requires a medication prescribed, I would make a note of it and prescribe it. If my nurse was leading it, she would make a note of it and send a prescription request to me, and I would issue it the next day. We document everything on our patient health record, which is EMIS where we are, or Systems 1 wherever you are. So as long as it's documented that they attended and you had a discussion, then the prescribing is safe because we have access to their electronic health records.
Absolutely. And what we often find is that clinicians will say to their facilitator, can you make a note on the car park that I want to start this medication for this patient or whatever? Then the clinician can go away and go into the patient's records and do the prescribing with the record, and then send the prescription to the patient's pharmacy or whatever immediately. So there's no more kind of admin involved in prescribing in a group clinic than in a normal appointment, so to speak, and you do have access to the records. So that's often a sort of thing that people worry about, but it's not an issue. So Jack has asked about facilitators and coordinator. I thought it was about whether there was a cost for them to be part of the group, but do you want to tell us when you did your lipid ones, who did you use as your facilitators and coordinators, Saloni? Who was it within the workforce that you use for those roles?
So in terms of facilitator, I guess there's a couple of roles. So one is your clinical facilitator and the other one is your technical facilitator. So we have always run it with 2 people, not necessarily the same role, but 2 different people. So I have facilitated as a GP, so we have GP facilitators, we also have nurse facilitators, and we have the R's roles facilitating as well. Effectively, anyone that has an interest or desire to facilitate can. They don't have to be clinical. We've had one time our admin team facilitating together with the GP, and that seemed to work really well. And it's just as long as you have a 2-person dynamic that you can use in someone that's interested, that's fine.
Absolutely. So that's what you said just then at the end. It really does fit very well with our best practice. So the best practice would be that you have your clinician and then you have a person who probably is non-clinical as the person who's helping with the process facilitation, so to speak. So they don't need to have the clinical knowledge, and they help and support the clinician with documenting, managing the group dynamics, all that kind of thing, just as Alicia described at the start of the session. So we've got one more question, I think, which is in the discussions. So, and Sophia asked this question, what topics do you cover? So I'm guessing I'm not sure whether Sophia was referring to your CVD or your cancer ones, but do you want to give us a little bit of a quick insight into both if we've got time, and then I'm going to hand back to Alicia to finish the session up for us.
So with the hyperlipidemia, what I would initially do is my facilitator would ask a question to the group before we started if there were any particular topics they were concerned about, and then we would steer our discussion according to that. And as we found in almost all the group settings, the same topics came up. It was nutrition, physical exercise, medication, monitoring and going forward, stress and sleep. Those tend to be the same. And those are what we use in our lifestyle medicine discussions to have a real holistic plan for our patients. If there was something that this particular set of patients were more interested in talking about, for example, background on what cholesterol was and more on education, then we led the group on that. If they wanted to talk more about medication. So it was really led by the group. And as facilitators, we were prepared to discuss anything. And because it's at a group level, you're not really going into in-depth statistics or anything that's really challenging that you'd have to, study or prepare for. It's just what you would generally advise your patients. So I would lead by the group.
Absolutely. And I guess that particularly with sort of something like lipid lowering, you always end up talking about like risks and benefits with lipid lowering agents. People have always got concerns, haven't they, about muscle ache and that kind of thing. And the beauty of being in that group environment is that you can, if you know that there's someone in the group who's taking a lipid lowering agent, you can ask them to share whether they've had any side effects. And that often is even better at allaying patients' fears about side effects than what you might say is what clinicians often tell us. So, it's lovely to hear how that is led by the group, and really good to know that it doesn't, you don't feel out of your depth. But if there is a question that you can't answer, everybody, just remember that's why you have your car park. So you can car park that question and say, I don't know the answer to that just now, but I'm going to check it out and send you some information about that afterwards. So Saloni, thank you so much. It's been brilliant to have you here and hear your story around your group clinics. I'm going to hand back to Alicia to take the session 2.